Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abaleta from Roots Community Health, reporting for the week of April 21st, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. Last week, the ACIPV Advisory Committee on Immunization Practices, the committee that advises the CDC, held their first meeting of 2025. And in the meeting, they did discuss a number of topics, including Mpox vaccine for adolescents. They talked about flu vaccine and how it performed so far in this recent flu season. They talked about RSV and Pneumovax, a number of other things. I am going to hold off on reviewing much of this, including the flu discussion. A lot of important aspects regarding flu won't completely be known or shared until the season completely finishes and they finish all their analyses, so that will be forthcoming. But in this week's briefing, I'll review the COVID presentations and discussion. They are timely and they provide new data or data that is just presented in a new way that can help inform us. And I think the discussion lays the groundwork for the June meeting, which is where they will be taking up votes on the COVID vaccine. And first, we'll do our usual respiratory virus and also now measles update. So let's jump in. First, taking a look at respiratory viruses among patients who present to a healthcare setting for testing. Flu cases in the bright blue continue to come down. Right now, the largest share of cases is made up by rhinovirus, enterovirus in the gray line. And we can see now that the flu in the bright blue has even dipped below human metapneumovirus in the black in terms of the percentage of cases. So we don't have any specific treatments for rhinovirus or enterovirus or human metapneumovirus. But it is interesting to note that right now, folks presenting for medical attention with respiratory illness are currently more likely to have one of those viruses than flu or COVID. And of course, as we talk about here often, it is still important to rule out COVID and flu, especially in those people who would receive treatment if they're positive, because we do have treatments for those two illnesses. So even though they may not be the most likely, we still want to be sure to rule it out. And right now, while COVID and flu burden is coming down for the most part and is relatively low when we compare it to other times of the year, I think it's helpful to take a look at epidemic trends. And so this is where modeling is used based upon emergency department visits, kind of an early warning system to determine whether cases seem to be going down, staying the same, or going up. So taking a look at COVID epidemic trends, Minnesota in the lighter purple color is the only state where it looks like COVID is likely growing. Many states represented in gray are not changing. And there are a number of states in the shades of green that are either declining or likely declining. The white is where it was not estimated. And that can be either because of incomplete information or because the number of emergency department visits is too small, like less than 10. Or because for whatever reason the data had issues or did not pass their reliability tests. And if we take a look at flu epidemic trends, only Illinois, for whatever reason, seems to be growing. We can see that most of the country is declining or likely declining, represented in those shades of green as it relates to flu. And then a number in gray are not changing. And taking a look at hospitalizations from COVID, flu, and RSV, we can see that flu hospitalizations in the blue have continued to decline and now have actually crossed below COVID hospitalizations represented in orange. And we would expect COVID hospitalizations to remain above flu and RSV until we get to next flu season. Similarly, when it comes to deaths, so deaths are actually decreasing right now from both flu and COVID. So we can see the curve overall coming down, but flu deaths in blue are decreasing faster than COVID deaths in orange. So as a result, we now have more COVID deaths than flu deaths. And again, this is something we would expect to be the case until we are well into our next flu season. But overall, in this past respiratory virus season, we had 9 weeks where there were more influenza deaths than COVID deaths. And still, like I mentioned, COVID deaths are coming down. There were 419 COVID deaths for the week ending March 22nd. And because we've seen hospitalizations and emergency departments trending down or leveling off since then, we would expect deaths to follow behind and continue coming down as well. So hopefully this trend will continue for a while. The lowest number of deaths from COVID that we've had in any single week since this whole thing got underway was early last summer, the week ending June 8th, 2024, when we had 314 deaths. So that was our all-time low. So it would be great if we could break that record this year. But that all-time low point was then followed by a huge summer wave where we ended up with over 1,000 deaths per week for about 2 months. So most of August and September of 2024. And I do think that is a big question mark. How will we do this summer? Some of it is a wait and see, but hopefully some of it is also identifying how we can do better this year. I think a big part of it will be ensuring that those who should be on the more frequent vaccine schedule, so the twice yearly, for example, schedule, should get that second dose, ideally before we head into a summer wave, before traveling or doing other activities that might increase exposure. Of course, protecting yourself if you're going to be doing traveling or higher risk activities. And then there is, of course, also timely testing and treatment so that we can reduce the risk of hospitalization and death. And for most people, the treatment is going to be Paxlovid, but it's really important that you talk with your primary care provider and have a treatment plan in place, because the window of time, as you can see in that far right column, is pretty short. And definitely, if there's some reason why you cannot take Paxlovid and you're going to need to go to one of the other medications, it becomes even more critical that there is some planning and some conversation with your primary care provider ahead of time. So in general, if you're someone who should receive treatment, if you test positive, it might be worthwhile asking your primary care provider, what happens if I get COVID and I can't reach you, or there's another doctor on call? It's possible they may be open to getting this sorted out ahead of time for you. They might be open to putting an order into the pharmacy or putting a standing order in your chart so that if there's any other providers covering for them, they'll know that that was their intention. So a little conversation and planning ahead can really make all the difference, especially knowing just how common COVID infections still are and will continue to be year-round. And regarding flu, things are definitely finally slowing down. So far this season through April 12th, we've had about 46 million flu illnesses, 600,000 flu hospitalizations, and 26,000 flu deaths, including 198 pediatric deaths. So another 10 pediatric deaths were added since last week. This is still too many children that we have lost to what is in large part a vaccine preventable death. And this is consistent with what we heard in last week's ACIP meeting. We'll revisit that data, like I mentioned, once we have more final data from the season, but no doubt, really the biggest risk factor across all of these children is that they were unvaccinated. A brief update on the U.S. measles situation. As of this past Thursday, April 17th, there are 800 confirmed cases, many more presumed, but so far 800 confirmed cases. This is up from 712 last week. So far, 85 individuals have been hospitalized. There have been 3 deaths, 2 children, 1 adult, and really 4 if we count the man who died in Mexico, also in connection with the West Texas outbreak. I think it is notable, like I've been mentioning, that 94% of cases, so 751 out of 800 so far this year, are outbreak associated. So by comparison, only 69% were outbreak associated in 2024. And if you add the confirmed cases in Texas and New Mexico, you get 661. So out of the 751 outbreak associated, the vast majority are from the West Texas outbreak, but there are a number of other smaller outbreaks. Outbreaks are defined as 3 or more linked cases. So there are definitely smaller outbreaks happening in other parts of the country as well. And whether it's a small outbreak or a large outbreak is pretty much completely dependent on the rate of pre-existing protection or immunity in the population where it's introduced. And most of the time, especially in schools and public settings, this has everything to do with vaccination rates. So as a reminder, last year for the entire year in 2024, there were only 285 cases. So already in 2025, we've already had more than 2.5 times the number of cases that we saw for the entire year of 2024, and many more of them are outbreak associated because of low vaccination rates. So definitely concerning about how we're going in the wrong direction in this regard. Remember, measles is highly contagious. It can lead to respiratory failure, brain inflammation or encephalitis, and death. And really, we've said that it can cause death in 1 to 3 per 1,000, even with the best medical care. But in this outbreak, we actually just talked about there's been 3 out of 800 infections. So this is even higher than what we've estimated in the past. This is something we'll have to just keep monitoring. This is a little bit new for us to be dealing with this on this magnitude, at least, for a couple decades now. And also important to remember that measles seems to wipe out parts of the immune system. So antibodies you've developed previously from prior vaccines or prior infection can actually be wiped out. So you become susceptible to more infections even after recovering from acute measles. And now going to review last week's ACIP meeting. So again, that's the Advisory Committee on Immunization Practices. This is the committee that advises the CDC about vaccine recommendations. So it's all about vaccinations, and they typically meet 3 times a year. This meeting was actually supposed to happen in February, but you might remember that it was postponed until now. So I think we weren't really sure what to expect. Overall, it seemed like a pretty normal meeting, packed with data and information and some discussion. There were a number of technical issues. One of the committee members actually referenced the recent reductions in force at the CDC, and apparently that includes their communications group. They actually had to stop and provide a new link partway through the meeting, but they managed to get back and stay on track. So this is 2 full days of meetings discussing everything from flu to Lyme disease to Mpox vaccines. Before I dive into the highlights regarding COVID, I'll mention the votes that they did take. They were on 3 things: meningococcal vaccine, RSV vaccine, and chikungunya vaccine. So with meningococcal, there's a new 5-strain vaccine against meningococcal disease. So that mostly we worry about causing meningitis. And this just goes into the routine vaccination schedule for young adults. And they approved this 5-strain vaccine unanimously, including a companion vote to add it to the Vaccines for Children program so that it will be free for eligible children. RSV vaccine. So this was previously recommended for all adults 75 and up, and for those 60 to 74 with increased risk of severe disease. Now that recommendation has been lowered, and so it is now approved for adults, also adults 50 to 59, who are at increased risk of severe disease, and that they should receive a single dose. So the meningococcal vaccine was approved unanimously. The RSV vaccine was 14-0 with 1 abstention. Chikungunya vaccine is for those traveling to affected areas. This is a mosquito-borne illness. It's been spreading in many parts of the world, and this is a new vaccine, and it was approved 14-0 with 1 abstention. So now I'm going to focus in on the COVID presentations and discussion. It's timely, and it provides us either some new data, new analysis, or data kind of presented in a new way that I think is helpful. And the discussion is going to help us understand what it is that the committee is going to be taking up in June regarding the vote that they will take then on the COVID-19 vaccines. So they started off with the current vaccine recommendations. I think we're all pretty familiar with those. Basically, we know there's a primary series for children. It's recommended 6 months and up, and then it's basically an annual vaccine recommendation for everyone, and twice a year for those 65 and up, and with immunocompromised, and it could even be more frequently for those who are immunocompromised, with shared decision-making with their provider. Then they dove into some data I thought I'd share, because even though we go over data here every week, they presented some of it a little bit differently, and they did share some helpful analyses. So if we're looking at COVID deaths, normally we look at this slide, which here we're seeing 2020 to current, showing weekly deaths. Another way to show this is using line graphs where each line represents a year. So it's the same data, but it's just looked at a little bit differently. And the first year being shown here is 2021 and 22. This is the first full year where we really had vaccine for all age groups, and this is shown in green. And of course, this is when we had the most COVID deaths, but you can kind of see that each of the years presented here, we essentially had two peaks or surges in deaths. And the first one is earlier in the earlier part of the year, so the winter surge, and then the next one is somewhere around summer or even early fall time period. So that's further over to the right. So the winter surge over to the left, and the summer fall over to the right. And what we notice for the top three lines, which is the first 3 years being depicted here, is that the first bump, the winter surge, is larger than the late summer, early fall bump, and the one that follows it. But then also in the next year, the winter surge has been bigger than the summer wave that was before it. So for example, if you look at the purple line, the first bump in January, so the winter surge, is higher than the fall surge the year before it in the dark blue. And it's also higher than the summer surge after it, which is in the purple. So the big thing that's different here, something that I've been talking about each week, is that when you look at this year, which is at the bottom, and is not done yet, obviously, the winter surge is actually smaller than the summer fall surge in the purple before it. So the bump over to the right in purple is 23-24. That bump is actually larger than the subsequent winter surge that we just had. So as I've mentioned, we don't know if this is a trend that's going to continue. For example, will this summer surge be bigger than the winter surge we just had? Of course, we hope that is not the case, but clearly this is a new occurrence. This is the first time this has happened in the pandemic. And while we can certainly hope that this just means things are trending down overall, only time will tell. And taking a look at hospitalizations represented the same way, we really have the same or kind of similar finding, which is that every year, with the exception of this year, the winter surge was bigger than the summer surge before and after it. So if you look at the light blue line at the bottom, which is COVID hospitalizations, you can see that the bump over to the left there, that is our winter surge, is actually smaller than the summer surge before it, which is in the red. So again, time will tell if this is something that repeats or if this was an. Now here we have a chart that tries to assess the disease burden of COVID and from flu from October 1st, 2024 to March 22nd, 2025. So this is really an attempt to compare COVID and flu for the same time period. And we know that this is only telling a part of the story because, as we just talked about, in the last 12 months, COVID actually claimed a few thousand more lives outside of this time frame than during this time frame. But nonetheless, this table helps us to compare the disease burden of flu to COVID during the flu season, even as we acknowledge that the COVID season is essentially the entire year. So I'll come back to this chart. But to that point about being year-round, I wanted to share this slide from one of the later presentations that helps to demonstrate this. So each bar here is showing a different season, with the red part being what we usually call respiratory virus season, and the pink showing May to September, which is generally not considered respiratory virus season. But many of the COVID-associated hospitalizations are in fact happening during this time period. And as I mentioned, when we look at deaths for the past year, we can see that we had a few thousand more deaths outside of respiratory virus season than during respiratory virus season as well, at least according to the preliminary numbers. But nonetheless, let's get back to comparing flu and COVID during respiratory virus season only. So we can see that in each of these boxes, there's a very big range of what we're looking at. So I think it might be most helpful just for purposes of comparison to look at the most optimistic scenario, look at the lower end of each of these ranges in order to compare. So if we start at the left and look at illnesses, we can see that on the lower end, under 8 million illnesses for COVID and 44 million influenza illnesses during this time. So nearly 6 times more flu illnesses than COVID. And if you look at outpatient visits, 1.9 million compared to 20 million. So about 10 times more influenza outpatient visits compared to COVID. And looking at hospitalizations, you see nearly double influenza hospitalizations compared to COVID. But then when you look at deaths, you can see that the number is very close. So what does this tell us? This basically lets us know that the risk of dying from a COVID infection is actually significantly higher than the risk of dying from any given flu infection. And the presenter also brought up that this does not tell us anything about long COVID. And I would say in general, I was encouraged by the fact that long COVID was brought up several times during this meeting. Several committee members indicated their level of concern regarding long COVID. So I took that as a good sign, but obviously this is not contemplating any post-viral conditions at all, but it is showing very clearly that the risk of death from any given COVID infection is much higher than the risk of death from any given influenza infection. So this was all kind of introductory data to lay the foundation, and we'll get to some more data in a moment. They did also share what is supposed to happen next. So in terms of a timeline in the spring, we expect that the FDA's advisory committee, so the Vaccines and Related Biological Products Advisory Committee, or VRBPAC, they're expected to meet and discuss and make recommendations on the strains that will be included in the 25-26 COVID-19 vaccines. Then in June, that's when the ACIP will meet again, and that's when they plan to discuss and vote on the recommended use of the vaccines. So we'll talk a little bit about the discussion they had and about how they're thinking about the COVID-19 vaccine recommendations in a moment. But just know that this April meeting, there was no decision made, but they did give us a good preview into what they're thinking about. So there is still time to weigh in and provide comment on the actual COVID-19 vaccine recommendations coming up. And then in late summer, early fall is when we can anticipate that the 25-26 vaccinations will be distributed and made available. But first, I wanted to share the presentation, or a little bit about the presentation regarding a new vaccine candidate. And even though I know that a lot of us hope that by now we'd have like maybe a nasal vaccine or a more broad vaccine that could help protect us for maybe for longer, we're not there yet, but I still wanted to take the opportunity to share something a little bit promising about this new vaccine candidate that is being called mRNA-1238, and this is a Moderna vaccination. So first, just a reminder, since we haven't gone over this in a very long time, the SARS-CoV-2 structure is shown at the top here. And of course, we remember the spike proteins. And at the bottom, you can see a representation of the entire spike protein. And as we know, that is what our vaccines have been fashioned against. But we know that the spike protein has different parts to it. And in particular, the receptor binding domain, which is the main part that connects to our ACE receptors in our body. And the N-terminal domain is where we can generate antibodies that are thought to be some of the most important antibodies to be generated. And so what Moderna has done is actually created what they're calling a next generation COVID vaccine. So it gets a little more specific than just being against the entire spike protein, and it is formulated against a smaller part or smaller parts of the spike protein. And these are the parts that seem to elicit the most robust response. So what this also allows for is a lower quantity of the vaccine needing to be administered. specifically 1/5 of the dose compared to Moderna's current vaccine. And again, you can see all of their slides if this is something you're interested in. They walked through safety and side effects and efficacy of this vaccination. The study population included individuals 12 and up, and they had pretty good race and ethnicity distribution as well. What they found on the side effect front is that local side effects like a sore, painful arm or redness of the arm was less, a little bit less with this formulation, which kind of makes sense because the lower volume, so less solution that you are injecting. But when they looked at systemic reactions, it was really pretty similar. So the ones that we're familiar with these vaccines, like headache and fatigue and body aches and so forth. So basically, it was similar to the current Moderna vaccine. There was no imbalances in any of the adverse events comparing the two vaccines. And they did not see any myocarditis or pericarditis in individuals who got mRNA 1283. So no safety concerns were identified. And it kind of makes sense that the local reactions were less because of the lower volume, and the systemic reactions were about the same. That would indicate roughly a similar systemic response, or that basically you're mounting a good response to the vaccine. And then they took a look at the antibody responses, and they did find consistently higher antibody responses in the mRNA 1283 group compared to the current Moderna vaccine, particularly for individuals 65 and up. Then they looked at who actually got COVID after having this new vaccine and what their outcomes were. And they looked at positive PCR test plus at least one symptom to define getting COVID. What they found is that the vaccine efficacy in the study was higher than their current Moderna vaccine for folks who are older, as well as those who had underlying conditions. And it was actually significantly higher than when you looked at the Moderna vaccine in these groups. So Moderna believes that the mRNA 1283 can further reduce the burden of COVID, especially among those who are more vulnerable to a severe outcome. So they are hoping to get it approved and manufactured and distributed in time for the 25-26 season. And it sounds like they would like it to be included some way in the recommendations that they'll be voting on in June. So I'm sure that there will be more to come on that. And now I'll just go over a few more data slides before reflecting on the committee's discussion. So I want to walk through this slide because I think it lays out nicely something that is truly under-recognized, and that is the seriousness of COVID-19 for our smallest children, in addition to what we already know about the seriousness in elders. And even though in general, we try not to compare children and elders because it really is comparing to apples to oranges, and it's not something that we would typically do. But at the same time, this slide, I think, does put it into perspective. So there's a lot going on in this graph. I'll try my best to walk us through it. Each of these groupings is showing a specific age group. So on the far left, you have the under 6-month-olds, and over to the far right, you have the 75-year-olds and up. And within each of these groups, we see 6 bars, and those are each representative of a year of COVID. So the light pink bar, which is the 6th bar in each grouping, represents this year, which is, of course, an incomplete year. So if you just look at the past couple of years, so 22, 23, 23, 24, 24, 25, you can see that, of course, the greatest burden of hospitalization is in those 75 and up. However, the next most impacted group is actually the under 6 months old group, and then followed very closely behind by the 65 to 74-year-old group. So this is, of course, disturbing to see. I know that I've talked about this many times, but it's not that often that we get to see the data really laid out like this for hospitalizations. And this should definitely concern us all. One of the committee members brought up the importance of looking at the recommendations for maternal vaccination, because we know that vaccine recommendations for the COVID-19 vaccine for 6 months is for 6 months and up. And when we're having this many babies being hospitalized below 6 months, it will be important for us to figure out what was the status of mom and maternal antibodies so that we can make the best recommendations possible. So it is true that there is a vaccine recommendation for during pregnancy, but I think what the committee was asking for was data to help us understand what is going on with these babies under 6 months of age that are being hospitalized and what was the status during pregnancy in terms of vaccination or even just the antibody status of mom during the pregnancy. So this could help us make the most informed decisions to keep baby safe as possible. So even though hospitalizations have been coming down since the 21-22 season, it really doesn't seem to be coming down enough, and too much of the burden is happening in our smallest babies. And further underscoring the burden among children is this slide showing that out of children and adolescents who go to the hospital with COVID-19, 1 in 5 of them are admitted to the ICU. So we all know how serious it is for anybody to go to the ICU, but for a child to go to the ICU is truly terrifying for everyone, the families. It's not something that you easily recover from, both the patient themselves as well as just the stress and the strain that it places on the entire family. And so now this is just looking at a time period of July to this past March. So just over March 2024. So just over a 9-month period of time that ended March 2024. And this is showing the percentages in each age group that went to the ICU. So highest in the 12 to 17-year-old age group at 27%, but really over 20% or over 1 in 5 in each of these age groups. And if you look at the table over to the right, it lets us know what percentage of those children who went to the ICU had no underlying condition. So notice that over half of the children under 2 who had to be admitted to the ICU had no underlying conditions. So there is a lot of variability from age group to age group with this, but on average, 41% of children admitted to the ICU had no underlying conditions. When it comes to the under 2-year-olds, it's more than half. So this is another misconception that we've been dealing with quite a bit as it relates to COVID, which is that the thought that most people who get very sick must have underlying conditions, which is a problematic sentiment in the first place, but is especially untrue when it comes to children. And I think that data is shown clearly here. And further to this point is this slide, which there's a lot going on here, but let's try to break it down. This is really showing us that particularly in the younger age group, so if you look to the far left, you can see the 6 to 23-month-old age group. So this is the under 2 age group, and 58% of those children had no underlying conditions. So only 42% had more than one underlying condition. So that means 58% had no underlying conditions. And then for the ones that did have an underlying condition, the most common is prematurity. And prematurity is not an uncommon thing. So once again, more than half of children under 2 who were hospitalized with COVID had no underlying condition. And when you look at the older age groups, you can see that one of the top underlying conditions is asthma. Again, asthma is a very common underlying condition. So this is just something to keep in mind. And then we also see that children with neurologic disorders, obesity, heart disease, among others, are placed at increased risk. And this graph is showing that out of all the children and adolescents that were hospitalized with COVID, over 95% of them had not received the COVID-19 vaccine. And this, of course, should factor into how we're thinking about vaccine recommendations for COVID-19. So this is only looking at hospitalizations where COVID-19 was the presenting reason for them being in the hospital, and less than 5% of them had received the vaccine in the preceding 12 months. And while we know and acknowledge that the vaccine does not do a great job of stopping infections, it does do a great job of reducing hospitalization and death. And so this is something we need to keep in mind. So the final section of the COVID presentation was really a deliberation about whether there should be a risk-based recommendation for the COVID vaccine or a universal recommendation for the COVID vaccine. And they did not vote or make any decisions today, but the discussion did give a good window into what folks were thinking. And what they mean by a risk-based recommendation is basically that the vaccine would only be recommended to people with underlying conditions. They pulled up the list of all the underlying conditions, and even when they removed some of the conditions from there, They pointed out that even still, about 74% of the adult population, in fact, has at least one underlying condition that puts them at risk for severe outcomes. So that's something to keep in mind. Furthermore, as we just saw, when it comes to our younger age groups in which there is a significant risk of hospitalization and ICU, even without an underlying condition, again, we need to be thinking about how these recommendations can follow what it is that we're seeing here. So I think that there were some on the committee that were actually surprised that a risk-based recommendation was even being considered. Then there were some who seemed to like the idea, at least in theory, of tailoring the recommendation for an annual vaccine to those with higher risk, but they expressed some worry about how this would be implemented in practice. This is why it's great to have practicing physicians on the committee. They pointed out things like the fact that this might make it confusing for their patients. It might make it so they can't get covered by their insurance. And one physician pointed out the reality that with a lot of patients getting vaccines at the pharmacies now, pharmacist doesn't necessarily have a way to know about all the underlying conditions that a person has, and a person might not feel so comfortable at the pharmacy counter just talking about their underlying conditions. So there was some mention of the fact that even if they did make a risk-based recommendation, that they would be so-called permissive, meaning that anyone who wants the vaccine could get it, even if they're not within the recommended groups. But then that brings us back to the concern about access and insurance coverage. Committee members did ask for additional information and data to be brought back before they have to make a decision in June. And I was glad to see that that included a request for data regarding long COVID. So a concern from one of the committee members was that there would be groups that might not be considered in the risk-based recommendation, but who may have their risk of long COVID reduced through vaccination. So they wanted to see some modeling that would shine some light on that issue. So I am hopeful that those are data that will be shared prior to the decision in June. And you might remember that the reason this committee meeting was postponed from February to April was supposed to be to allow time for public comment. And it seems that there was quite a bit of public comment, especially around getting the Novavax vaccine approved. We did not hear any update about that, but they said that there will be an update forthcoming. But there will be an opportunity for public comment before the June meeting as well. So if you have thoughts about the risk-based versus universal vaccine recommendations, there will be an opportunity to bring those forward. So in the meantime, let us remember our best practices to prevent the spread of respiratory illness. And if you don't have a primary care provider, please get one. And let us try to eat a balanced diet, quit smoking, avoid alcohol and sugars and processed foods and artificial ingredients. And if you don't feel well, make sure you get your rest. Otherwise, get some regular physical activity, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. We will be taking next week off, and we will see you the following Tuesday at 10 a.m. See you then.